Hi, good evening, everyone. I'm Dr. Philip McMillan, and today is the 6th of June, 2026. And I'm taking on a topic here that I think is very important. In truth, I've been traveling today, and because it's tiring, sometimes you need to stay awake. And so part of my exercise of being awake was to think about the relevance of vagal nerve inflammation in severe COVID and long COVID. Now, this inflamed throat may seem to be quite subtle. And as I said, I think this conversation is a little bit ahead of its time, which is why I'm recording it and which is why I'm time stamping it. I think that what I'm going to say here may be better understood in a few years' time. So you have to understand that I am linking together pieces of research that I've been doing over a number of years and in what we are actively doing because our small research team, we take on lots of complex topics. And what one of the things we're doing and focusing now is we're trying to explain exactly what happened in terms of the molecular changes with severe COVID. And part of that work means that you have to go back to all of the questions. And one of the questions that popped into my head was happy hypoxia. Now, I don't know if you've heard about it, but it's a very unusual pattern that occurred in severe COVID, and it made no sense clinically. And we've never really got a full explanation for it. There have been research coming up with ideas, and similar to what I'm going to do, I'm going to be giving you some ideas around it. Now, in case you don't see any further, one of the things that I want you to do is make sure if you have ongoing symptoms and you think it could be your vagus nerve, make sure you click on this link because there is a screening questionnaire that just helps people to understand a little bit more about their symptoms. And you can just do it on this link here. It's free. You don't have to do anything else. There is some guidance about gut related symptoms, but just having an understanding as to what may be going on is quite valuable. So let's break down what was unusual in the pandemic. There was a pattern called happy hypoxia. This is a clinical kind of description for what we saw. People would come into hospital with very low oxygen saturations. Now, in case you don't know anything about oxygen saturations, whenever someone comes into hospital, we usually put a monitor on their finger and it will show us their saturation levels. And normally it's above, say, 94%, up to 100% if you're, say, breathing on oxygen or something. And if you have like COPD, it may be between 88 and 92%. And we can accept that if you have known lung disease. But if you are a healthy person with no significant lung disease, if your oxygen saturations were even less than 90%, you would feel extremely short of breath. And this is what was very unusual in the pandemic. People would be coming into hospital with saturations in their 70s, and they're talking to you as normal. It was so freaky. It was really unusual. Then you'd stick oxygen on them and you'd realize, goodness, this person probably has COVID. And it was so characteristic that we could use it to identify when a patient had relatively moderate to severe COVID. The problem is we never really had a good explanation for it. And this thinking that I'm talking about today is linking a number of things together that are connected with this happy hypoxia because the research showed that if you had happy hypoxia, you tended to have worse outcomes. And it wasn't just about the fact that your oxygen levels were low, it tended to indicate that you had more severe disease. So the first question, just in case if you're clinical, is quite practical. How in the world is it possible? So follow this here. Now, this is the science here that I'm talking about. When your oxygen level gets low, There are signals that can come from the lungs, the aortic body, or the carotid body. Now, what happens is, let's zone in first. If someone blocks air to you, if you're being strangled and there isn't any oxygen getting into your lungs, it fires signals to the brainstem that lets your body know that there are problems with exchange of oxygen in the lungs. So that's one point of signaling. The next one is the aortic body. On the aorta, they have a little body that measures oxygen sensation. And if that starts to drop, again, it sends signals to the brainstem so that you breathe more quickly. A third one is the carotid body. And this one is in the neck, where it again is one of the very powerful signals that if your oxygen levels go low, it fires signals to let your brainstem know this is not right, and you increase your breathing. Very important mechanism that the body uses to try and help you to breathe. Okay. So, what was unusual was that these patients didn't seem to be getting the signal from any of those locations. So, in order to have happy hypoxia, where your oxygen saturations are low, you don't recognize that your oxygen saturations are low, it means that all three of those signals have to be blocked. Now, if you're clinical, yes, I'm happy for you to challenge that point, because if you can come up with another reason, then certainly please explain it. Now, early in the pandemic, my view was that this was because of ACE2 being on these bodies. And so, therefore, when you had this autoimmune response, it would block the function of these carotid and aortic bodies. But I couldn't explain the lungs, because it's not the lungs, it has a different mechanism. It's not necessarily ACE2. So I knew that there was a hole there, and I suspect that maybe it can be filled with regards to some of the thinking that I was having today. So as I said, you're getting some of the mechanistic systems that I'm talking about today. So let's dig a little bit deeper here. So again, let's go through this. The lungs here, oxygen sensors, the aortic body, and the carotid body. Now, look carefully here. In terms of the lungs, the signal travels via the vagus nerve, cranial nerve 10, and it then goes up into the brainstem, where it signals to the brainstem there is a problem. The aortic body travels via cranial nerve 10 as well. Vagus nerve, again to the brainstem. But the carotid body doesn't use the vagus nerve. It uses another nerve, cranial nerve 9, the glossopharyngeal nerve, to send signals to the brainstem. Now, what's very important about this nerve is that it also carries a lot of the taste fibers. And you will remember that people also had loss of taste. So we had loss of taste, loss of smell, and happy hypoxia all occurring together. This suggests that there is something neurological that is not directly related to the virus attacking anything. This is my view, is that this could be inflammatory. The question is where? What could take out all of those things at the same time? Because as I showed you there, this is more than just the vagus nerve. It's the vagus nerve and the glossopharyngeal nerve. Now, when we did our research on long COVID, one of the 4 phenotypes was vagal, because we recognize that a lot of people have symptoms suggestive of vagal inflammation. And they would therefore have quite specific characteristics. And this is why, again, I'm mentioning, if you haven't done it yet, take a look at this framework here that we have got about is your vagus nerve inflamed. This is more about long COVID rather than the severe COVID, but the mechanism and the area that is affected may be very similar. Okay, so this is where we're going with regards to this. So let's go a little bit deeper with regards to this. Now, I told you about the two nerves, the vagus nerve and the glossopharyngeal nerve, and the three locations, the lungs, the aortic body, and the carotid body. So what could take out all three and include the taste? So now this is where it gets very, very interesting. All right. So as I said, this is a pretty heavy discussion. And I think that it's a few years ahead of its time because some people don't even get ACE2 autoimmunity after 6 years of talking about it. So can you imagine this? So let's take a look at this here. So now I'm zoning right in on the back of the throat. Now, this is very important because when the virus comes in, it not only affects the nose, so it infects there, up here in the nose, and the throat as well. And one of the things seems to be that this area of the throat gets inflamed. It's what we call the epipharyngeal region. Now, what's important about this region is that it seems to be also linked to MECFS. This is like chronic fatigue syndrome. And so it is a very important area from immune point of view. And so it's something that shouldn't be underestimated. And one of the strange things is that when you dig in the science, you sometimes stumble into things that could be relevant. And here's an overlap. In Japan, they found that patients with MECFS or who were chronic fatigue syndrome oftentimes had inflammation of the epipharynx. And when they did a particular strategy, just wiping zinc chloride on it, almost 2/3 of them improved. A third of them, the symptoms completely disappeared. Another third improved. It didn't help for another third. But that is very significant and very unusual. So it suggests that this part of the throat is extremely critical in terms of longer term, broader symptoms. And here is why. When you look very closely at this, there are two ganglions here. Now, you may not know what this means, but essentially, a ganglion is where nerves meet, connect, and continue. And so it's like a relay station. And so you have the vagus nerve connecting, and it connects it to two, the superior jugular ganglion and the inferior nodose ganglion. And at the same time, the glossopharyngeal nerve connects with the petrosal ganglion. All of these are sitting just behind the throat, very close distance. And so this is the bit that's really important. When you get inflammation in the throat here, the inflammatory cytokines may impact on the function of these ganglions and effectively block them. And this is the insight that I think is very, very important, because suddenly it would explain happy hypoxia. So it's almost like a significant inflammatory process that is occurring with the triggering from the lungs and so on. So the lungs are not getting enough oxygen, but because that area is inflamed, the signals are not getting through from 3 points: the lungs, the aortic body, or the carotid body. Now, this has implications, as I said, going forward, because it's now also relevant to long COVID patients, where it's almost as if this signaling part of the body is not working properly. In some people, they now have the sensation that they can't get their breath. They feel short of breath even when they have normal saturations. And it would suggest possibly an oversensitization in that region. And which is why one of the strategies that has been used is a stellate ganglion block, where inject uh, um, uh, they inject an anesthetic to block the sympathetic side, and it improves their symptoms. That would suggest that this is something very strongly linked to these ganglions, just in case you forget, sitting right in the neck region, right around the arteries, right at the very back of the throat. And when there is chronic inflammation there, they seem to be affected. Now, the reason this was standing out to me was because I was looking at the transition to very severe COVID, because it occurs quite quickly. When we think of what Dr. Chetty had observed, and I think this matches real life experience, he would find patients would have mild symptoms or symptoms day one, and he'd say, come in and see him. This was when in South Africa. And he then noticed that at day 8, just over a week after, if they were going to deteriorate, that is when they did. And what I was looking for was what was the transition point, because that's when they would come into hospital with happy hypoxia. They don't have that at day 1, but they would at day 8. And that suggests that at day 8, there is very significant inflammation occurring, and this is now my hypothesis, occurring that's impacting these critical nerve junctions that then blocks the signal so that the brain is not aware that the person is hypoxic. Really important signal. Now, let me just go over that, because I think this is now a really important point that some people may have missed if they had come late. And so I appreciate you guys being with me on this. This is some complex stuff, as I said. And here we go again. The point I was making: 3 signals tell the brain there isn't enough oxygen: lungs, the aortic body, and the carotid body. It seems that all 3 are blocked when patients get happy hypoxia. And so my interpretation is that it's being blocked at the point of the nodose ganglion in the neck, possibly related to inflammation in the throat region as well. Now, you may wonder why I was thinking about this. And as I said, this is part of our research. And I'm not even sure if some of these things I can put in the paper, because too much of it may be hypothetical with not enough research to support it. So I'm sharing the ideas so that when it's figured out 3-4 years down the line, I can come back to this video and say, I told you so. This was what I predicted at that time. So here is now where the link in my mind is very, very important. Because when you have this kind of inflammation blocking, say, the vagus nerve, it has implications for the rest of the body. Now, watch carefully here. This is a complex slide, but I'll try and take you through it. In the middle here is the brainstem integration. Forget the name, nucleus tractus solitarius. It's in the brainstem, but this is where it coordinates a lot of the autonomic responses or automatic responses. You don't need to think about breathing or your heart beating. It just happens, and it's oftentimes coordinated in the brainstem. Now, as we said, these signals from the lungs, carotid body, aortic body seem to be being affected. Now, this is coming into the brain, but this is part of the parasympathetic system, the vagus nerve, which sends output to multiple parts of the body as well. Again, to the lungs, to the heart and blood vessels. It controls the heart rate. It controls the gut, stomach, pancreas, and intestines. And this is the biggie. This is the thing that I've been looking at carefully, the mesentery in the intestinal region. This is like an organ on its own. It's wrapped around the intestines and it's filled with lymphatics. And I have predicted that this is probably where severe COVID may be coming from in terms of the surge of an immune response. But I can't prove it. There's not enough evidence here. At the moment, it is purely my hypothesis. But this is where the connection comes with regards to the blocked vagus nerve. So here is my hypothesis. I've said that severe COVID, even though the manifestations are in the lungs, is actually probably more of an intestinal disease, because once the virus breaks through the upper airway, it then heads to the lungs and the intestines. And so my prediction is that you have a rebound of an immune response. So when I focused on autoimmunity, I was looking primarily at the intestinal, well, I was looking at autoantibodies being produced, thought it was the lung initially, but it probably is coming from the intestine. And that rebound would therefore involve the mesenteric lymphatics, because there is a huge immune system there that is just sitting there and producing antibodies if needed. If this then becomes inflamed, and now this is the counterintuitive thing, follow along. So you have the inflammation occurring. The person has lost their taste after about 3 or 4 days. They then start to lose the hypoxic signal a few days before they then go on to severe COVID. When they hit the day 8, as Dr. Shetty is talking about, what is then relevant with regards to the mesenteric system is that the output from the parasympathetic is an immune brake. It keeps its brake on the immune system so that you don't get overactivity of macrophages in this region. And so therefore, what I'm predicting is that this is then blocked, and this is already happening, but you get an uncontrolled surge from this immune system because there are no signals coming from the parasympathetic to block it from happening. It is complex. So again, let me try and see if I can take you through my thinking here. I think that the vagal blockade happens in between day 1 and day 8. For people who have a severe response, which may be coming from the intestine, because that vagal blockade is not able to also dampen down the immune response in the intestine, that surge then causes the rebound to the lungs, which then leads to very severe COVID-19 with microclotting in the lungs, vasculitic features, damage throughout the lungs, and this can then lead to death. And so this is a staged, linked, whole system that until you understand it, it seems to make no sense. But there's a reason I keep focused on these things, because in this is important clues that are relevant to what is happening today. Because if this can happen in severe COVID, the mechanism, certainly of mesenteric inflammation, could also still be occurring with reinfection. It's just presenting in a different way. That's the bit that if you don't go back to the science, if you don't force yourself to try and come up with logical scientific explanations for what we have seen, it means you can't get insights down the line. Now, my insights may not necessarily be correct, but I know I'm pretty close to what is happening. And what I challenge other people to do, certainly if they're scientists or clinicians, think about it, look at it, reflect on it, because what we need now are people who are thinking, who are able to observe, who are able to tie these things together. I don't have to do it on my own. I'm just pushing out ahead and allowing my mind to go in directions that it wouldn't have gone if I was sticking to a narrative. That's essentially why I am here today with regards to these kinds of thoughts. And this is why I think that this may be a few years ahead of its time, because it will take a lot of research to prove these points. But sometimes by sharing the ideas and other people looking at them, we can get solutions that could make sense for the future. So, as a reminder, this may be relevant today for people who have persistent symptoms. And so if you want to check to see if your vagus nerve is inflamed, just jump to this page. It has a simple pattern symptoms here. So you can just literally jump through 7 questions, 90 seconds. You just click start and it just goes through each one of these and it gives you an idea as to as part of your symptoms. And so, yes, we are still extrapolating the science. There's still a long way to go in terms of understanding what has happened, what is happening, and what is going to happen, because this is not over. And this is why looking at the science is so important. You don't ignore it. You keep going. You keep trying to understand, because at the end of the road are insights that may be relevant, not just to the disease you're studying, but to other diseases as well. Appreciate all of you who are here with me. And I'm just taking a quick look at the comments here just before I go, in case people see. So here is somebody here who said, I agree with you, Doc. As a chest physiotherapist, I am seeing at least 3 deaths a week with pulmonary embolism to our hospital. Now, that one is going to be, that's pretty serious, and I don't disagree. That's going to be about the clotting that is occurring. One of the simple things I say is please just make sure people are not deficient in terms of vitamin D. Just looking through here, just in case anybody said something. This is one about for sure it's going to be as exactly as Gert predicted. Hivicron. I need to talk to Gert again, so I'm hoping to try and get in contact with him. Turbo inflammation for all sicknesses, and it's going to explode in the jab. Well, let's the only warning I say here, and not that I disagree, is that I don't want people to think that being on jab means you have no risks. I do think the risks are much lower, but there are a cohort of people who have ongoing reinfection with interferon autoantibodies, which is something I must do a full presentation on, that is relevant, that we have to look out for. And this is one I just got in. Extreme fatigue seems to be dragging people down. This is going to be connected with the vagal inflammation and probably epipharyngeal inflammation. It's very difficult for a lot of people who are struggling. The hypoxia, but not hypoxic comment reminded me of empty nose syndrome. I'll have to go look that up. I'm not quite sure what that is. But yes, thank you all for being with me. I appreciate your interest and the support. Remember to like and subscribe. Very few people are seeing these videos these days, and it seems that the algorithm is not so interested in them, but I know this is important stuff. So remember to like, remember to subscribe, remember to share. This is of value to other people as well, and we hope to continue to bring you these insights. Thank you very much and have a great evening.